Okay. So, welcome everyone to the Wellness Room. So this is my online webinar that I do every month as part of my business, so Be Lively. So I run a health and wellness business alongside my sort of nursing role and as well as a personal training role in sort of cancer rehab. And this business is mainly to try and just give someone the option to exercise at home with a healthcare professional that can obviously adapt exercise to their needs whilst looking at them quite holistically. I kind of also want to do these webinars mainly to kind of switch the paradigm in healthcare to be more integrative ones. So I'm hoping that if there are any sort of healthcare professionals that are watching this as well, that, you know, we can kind of explore that kind of interconnected and multidimensional aspects that influence health and well-being, and obviously just highlighting that nurses can be therapeutic partners in people's care, and that we should be more concerned with the whole person and not just their symptoms. So yeah, so my background generally is in, I've done cancer nursing, I've worked in emergency medicine and community nursing as well, which I've worked the longest. And I've spent the last year being a personal trainer, and I've recently been working in cancer rehab, which has been really exciting, and they are kind of at the forefront really of including exercise as medicine as part of someone's you know, healthcare, as part of their treatment essentially, so alongside the traditional therapies that we see in general medicine. So yeah, it's a really exciting field to be working in, and again, it's developing skills, so it helps people to gain the confidence that they need to kind of make meaningful changes in their lives. So it's always really about building confidence. So this is my second webinar, and the topics are chosen by my clients. So if they've got something they want to learn a little bit more about, they're the ones that drive the subjects for these webinars. And this month I am joined by the wonderful Abi Fernandez. Abi is a nurse, some of you already know Abi, but her main experience has been in women's health, ranging from obs and gynae, neonatal nursing and practice nursing. However, she has also trained extensively in sports and remedial massage, pelvic health, breathing mechanics, chronic pain and mobility rehab. So she truly understands the whole body, or essentially how the whole body works. And she's worked with people who've had unresolved sort of chronic pain, and she's made a huge difference to people's lives by looking at the deeper issues of why people have chronic pain. And I'm really excited because I know I'm going to learn a huge amount from her tonight, as much as you will. So yeah, so we'll get started in a second. Just a bit of housekeeping. So you will be muted throughout, but please ask any questions if you want to at the end, or you can pop them in the chat function if you're not confident enough to unmute yourself. Please do. Unfortunately, we can't give any kind of individualized advice, and obviously anything that you learn from this evening, if appropriate, it's, you know, it's always a good idea to kind of consult your healthcare professional, you know, your GP or your practice nurse or anyone like that before making any changes, you know, to kind of your exercise regime or anything like that. So I'll pop a link in the chat as well at the end to see if I've got a feedback form, and because I'm quite new to this, so I'm sure there's probably scope for me to improve on things, and then once you've submitted your feedback, I'll send you you know, a certificate of attendance within the next 7 days. So we'll get started, Abi. So I'll just move my thing. So to start off with, can you just tell us a little bit about the structure of the knee and why it's important in understanding what could go wrong? I'll just
sure.
There we
First,
go.
thank you for the lovely introduction. I'm Lauren Yasmin here with you. I really like the project you have enhanced with your business. Oh, thank you for the photo. That's very handy. I think when we think about knee pain, it's not quite as straightforward as always thinking arthritis. I have so many clients come in that say, oh, I have arthritis just because they have a pain that hasn't been resolving quick. There's actually many things. And I think understanding what is what we really have within the joint or within the knee, it will help us understand a bit better what can go wrong. So obviously we have the bones. So we have the femur there on the right side. You see it's like the big bone that comes from the thigh, and then we have the tibia and the fibula on the bottom. Oh, you have a pointer, isn't it?
Oh yeah, so you're going to ask me. You're going to ask me the point, aren't you?
So the tibia and the fibula. So that's it, the pointer there. So that comes from the lower leg. So the fibula doesn't really link or doesn't really attach to the femur or the patella, to like the knee as such. It does actually come just next to the tibia. So that it's a joint that doesn't really belong to the knee as such. But in my experience, when the fibula doesn't have good mobility, it can give lots of lingering issues within the knee. So it's something that definitely, if you have lingering issues, there is like the band tension feeling around the knee, something that someone has to check, and not everyone can. So osteopaths and chiropractors are quite good at that. Apart from those three bones, we have the patella, what we call the kneecap. So it's that roundy bit on the front, so you can actually touch it, and the patella should be movable. So when your knees relax, you should be able to track it to the sides, up and down. If it doesn't, that can be an issue, and that can give problems and pain, and obviously friction and other issues that we'll be talking about in the next slide, I think. Apart from having the bones, obviously we have as well muscles. So we have muscles coming from the lower legs. So we have like the gastrocnemius, which are not there, so the calf muscles. We have also the thigh muscles. So we have the quadriceps. So we see the big chunky muscles there on the top, and the rectus femoris is the one that crosses just on the front and has that big tendon coming from the patella all the way down to the tibia. So that can give muscle aches, but can also give tendonitis or tendinopathy, tendon issues. So that's a tendon from the patella to the tibia is a place where usually tendons can get a tiny bit grumpy as well. Apart from having the muscles with their tendons from the thigh and from the lower leg, we also have cartilage. So we have the meniscus, which lateral meniscus there on the right side. So I have the two meniscus, which are those cushions that are there within the joint to prevent friction. So they're proper cushions. And obviously, if they break or they have tears, usually they need surgical repair because they stay on the way, and then the knee starts clicking. And then we have ligaments as well. So if you stay there on the right, just over the meniscus, we have the ACL and the PCL, so the anterior cruciate ligament and the posterior cruciate ligament. And those basically keep the bones together, so the lower leg doesn't really displace forward or backwards in relation to the femur, so they keep the bones in place. And then apart from those, we have the collateral ones as well. So is that band of tissue that you see from the femur to the fibula there, and you see it as well on the left side as well. So you have the lateral collateral ligament, that's it, and you have it also with a point on the other picture, and then the medial one, so one in the inside, one in the outside, and those keep the bones together so they don't displace to one side or the other. So we have the ligaments supporting bone to bone, the tendons linking muscles to the bone, we have the cartilage, we have the muscles, and we have the bones. And as well, we have the cartilage that covers the ends of the bones. So it's that white lining that you see, that's it, that's the white lining there, just on top of the meniscus. So that's the end of the bone, and basically it's just kind of lubrication that allows the movement to be smooth. So basically when we have arthritis, that's the structure that gets damaged, and all that is then we hold within a capsule as well. So there is some fluid, synovial fluid, that keeps everything nourished, and that keeps all the nutrients coming to the cartilage as well. So everything is nicely lubricated to have a smooth movement. And so I think structurally that's basically it in a very simple and brief way.
Yeah, but it's quite a complex joint, isn't it? You know, we've got quite a lot of crossing over tendons there. So
it's like three joints really, because we have the fibula with the tibia, and then we have the patella with the knee, and then we have also the femur with the tibia. So we have those three structures, bone to bone, so those three joints within the one joint. Plus then, as you say, we have all the tendons in the inside, the outside, the back, the front, and then we have also all the ligaments within the joint, inside the joint. Yeah, it's quite a complex joint. I mean, the body is never so straightforward. There's always loads of things in every joint. There is some complexity, but I think the knee is one of those that really needs to be assessed very carefully, and that can be not misdiagnosed, but people usually have loads of misbeliefs around what can go wrong, and we usually just go into, I have arthritis, or I just have a bit of a torn muscle, and we kind of go into those two groups. And actually there's loads of things that can go wrong, because there's lots of structures.
Yeah, so that kind of leads us quite nicely to my next question. So what are kind of the most common injuries that can occur at the knee, and obviously conditions as well that you've seen?
I've seen loads of everything that can go wrong. So I think obviously every single structure can go wrong. So if we start with the bones can break. So obviously you can have fractures. If we think about the patella, for example, the patella can be a bit out of place as well. So instead of being nicely placed in that groove, in that kind of little sinking valley of the femur, it can be a tiny bit too high. It can be actually a bit losing the traction because of that tendon that comes from the rec fem, that white tissue that is holding in place. Maybe it's a tiny bit not strong enough, and it actually tracks off the place to the inside, or it can be too low or too high. So just the patella in the such, even if it's not broken, if it's not in the right place or it actually moves out of place, can give lots of issues. Then we have the muscles. The muscles can get overworked. So we can have also overuse syndrome, just because we just use them too much. We can have imbalance on the muscle groups. So we can have very strong quads and very weak hamstrings. So we can have short hamstrings. So we can have tight calves. So we can have some issue that comes from the muscles. And it's not painful inside of the joint. It's as such, it's painful around the joint. So it can hurt on the front, or it can hurt on the back, on the top of the calves, or it can hurt just behind the hamstrings, and that can be muscle. Then obviously the tendons can go wrong. So we can have lots of friction, and we can have, that's it, the patellar ligament and the tendonitis on the patella as well, because of the friction, sometimes in runners when there is poor traction and poor biomechanics. And we can have as well the ligaments. So we can have injuries in the ligaments. So the medial and the collateral and the lateral collateral also can have, if you have a trauma, for example, or if you just overextend to one side, they can get overstretched. With ligaments, there is always that mechanical force that overstretches the ligaments for them to go wrong. So either you get a twist knee and you can have an ACL injury because your dog came and just ran onto you and the leg just went off, or your kid was playing and just knocked you from the side, or you just fell off and twisted the knee. Rugby players, that kind of thing, they trap the foot on the floor and then the rest of the body goes. So when you overstretch the ligament, that mechanical force can damage them. The MCL, the LCL, mostly the MCL is easy to treat just with rehab, but ACL, PCL usually need surgical reconstruction to heal the problem properly. The same with the meniscus. The meniscus usually happen when you overextend, overflex, so you kneel down very abruptly, or you get the knee extended properly. Usually that happens as well. The ACL usually gets also one of the meniscus torn at the same time. When that happens, the meniscus kind of gets a bit of a tear, so a flap comes off and it stays there on the joint. So it needs also surgical reconstruction of that and just clean the joint.
I'm definitely thinking back to my that kind of housewife's knee, isn't it? You know, like district nursing, kneeling down on my knees all day.
That has more to do with bursitis, actually. So it's that fluid cushioning. I didn't mention it in the structure, but it's a cushion that stays on the outside of the patella and also can give that. So usually you get that, and as well a tiny bit of kind of bruising feeling in the meniscus. So the meniscus getting a tiny bit inflamed before it tears, and you can have both of them because of the kneeling, which I actually had when I was a practice nurse, both of them. So I totally feel you there.
Yeah, definitely.
And what else can go wrong? Obviously, we have blood vessels, we have nerves, so there is loads of other things that can go wrong. The tendons as well in growing growing male teenagers. The bones grow way faster than the muscles. Sometimes that tendon from the quads can actually get pulled away from the bone. That's very painful as well. And it's quite common when they're very tall and they grow so fast, just an inch a month, something like that. So there is loads of things that can go wrong. So I think the main key is when someone goes to have the knee assessed, you know when you're in the right place when they ask you loads of questions. I think it's key, asking and having a good history of the injury, good detail of how it happened, where it hurts, how much it hurts, what time of the day it hurts, lots of little details that will let you know what kind of a structure is the one that is damaged. And what can be going wrong. I think this photo here tells you a tiny bit how just the location of the pain can give you a tiny bit of an idea of what structures can actually be causing the issue. So obviously you can have pain within the joint, which might be more ACL, PCL, arthritis. You can have pain more in the muscles, just on top of the knee, which obviously that's more quadriceps and tendons. It can be on the inside or the outside, so usually that's either the meniscus or the collateral ligaments. So depending where the pain is, you can have an idea of what might be going wrong. Is it within the joint? Is it outside, the front, the back, the sides? So that can definitely give a good idea of what, and that will obviously then kind of guide the questions to ask, the tests to do, the assessment to do, the treatment and the management.
Yeah. So so with these injuries in mind, do any of those sort of predispose people to sort of developing arthritis in the future, or does that make it more risky for them in terms of developing arthritis? Or
so from all the things that I described, there is obviously risk factors for them, like obviously those latches will be the growing male teenagers and all that. Arthritis is kind of a big chunk, isn't it? Arthritis
there's a lots of them.
So obviously arthritis doesn't happen in young people usually, so it's something that we see as we age. So usually age is a risk factor, but there is many others. So females, so women have 40% more chances of having arthritis. So being a woman already puts you in a higher risk of arthritis. Obesity is definitely a high risk factor, not just because of the weight, because we need to take into account that all your weight is carried on your two legs, so your knees are carrying loads of weight all the time. The more the weight, the more damage that you do to all that cartilage that is lying in the surfaces of the bone. So the more that it wears and tears. But it's not just the weight. If you're obese, you have a systemic inflammation going on in your body, and inflammation can cause as well arthritis and develop arthritis. If you're a sport person, for example, and you had ACL injuries because of mostly if you're a woman and had an ACL injury, you have higher risk of then developing arthritis because the way your knee works afterwards, mostly if you didn't have rehab, then that puts you a very high risk. It's a bit different. The way the congruence of the joint is afterwards is not the same, so you have higher risk of arthritis. It's up to 7-8 times more if you had an ACL injury. So all those things really put you higher risk. But you can have risk for all the other things as well, like pregnancy is a high risk of having also ligament issues and muscle aches as well around the knee. Hormones have a massive effect in the laxity of the ligaments, so the periods can affect it, pregnancy can affect it, menopause can affect it. And once you have those changes, the biomechanics, the way you weigh the bed, the way the muscles get used, the way that muscle input and the neurological input into the muscles gets switched on is different, so then your body doesn't adapt the same, so you have higher risk of ligament issues. Once you have that clicking knee because of pregnancy or menopause and it doesn't go and it gets lingering, you have also higher risk then of developing arthritis. So I think arthritis is not just like I got it, like you get an ACL injury or you get an injury because of a trauma. Arthritis has loads of things. It's big. It just comes from building up of risk factors.
And I suppose it's like with anything, if you've got a genetic predisposition to anything, by adding those additional risk factors just by having those additional things increases your risk. So like with any disease. So
you cannot change being a woman, but obviously if you're a woman and then you have obesity or your diet is very poor and you add inflammation, obviously you have it.
So we've got modifiable and non-modifiable. So the ones that we can modify, again, like weight loss, even just with a 10% in people with arthritis, their knee improves with just a 10% in weight loss. Sorry, I can't get my words out, everyone, I do apologize. They can increase their overall functional score by 28%. So it's quite a good improvement, even with a relatively sort of small weight loss. So, I think that's reassuring. Brilliant. in terms of, so you've covered the sort of risk factors. Was there anything else you wanted to add there?
You're thinking about arthritis in a specific, yeah, I think exercise is definitely a big one, not just only for arthritis, but also for chronic pain in the knee. It is proven that sedentary lifestyle and sedentary behaviors really put people at higher risk of having less pain threshold, so more sensitivity to pain, and mostly in the knees, like higher pain on the knees. Do you think lifestyle, not just obesity, but being able to move, to exercise, to be active, is definitely a risk factor that we can modify, and it affects the way we feel the pain and the way the pain chronifies and stay with us for longer. Yeah. Obviously, we're not talking about injuries. If you have an injury, you need to have it sorted. We're talking about that pain that lingers, that pain that is within the joint, or that pain that doesn't have a diagnostic label because there is no x-ray, so the x-rays don't really find that imaging, doesn't have any diagnosis for it, and it's just idiopathic. We don't know where it comes, but you feel pain. Yeah. Those obviously lifestyle and diet and all the things that we've been discussing really have an effect and a risk factor to maintain that in time.
Yeah. And I suppose we should just clarify that we're talking about osteoarthritis rather than rheumatoid arthritis. Yes. So, you know, osteoarthritis, you know, historically was, you know, it's kind of termed the wear and tear arthritis, isn't it? And, you know, in terms of, you know, we know what those risk factors are for that now. And is there, and some people experience more pain with osteoarthritis than other people. So, you know, in your sort of experience, you know, what sort of drives more sensitivity to pain than, you know, say like, I know that some of the evidence was saying that women particularly experience more pain than men. So kind of what's driving that?
So there is, again, lots of modifiable things that we can modify and things that we cannot modify. Like being a woman, it is proven that we are more sensitive to pain. Hormones play a big role there. So the lower progesterone through menopause as well, that depending on the time of the cycle we are after pregnancy, we are more prone to feel more sensitivity to pain. And we're also more prone to catastrophize the pain, to feel more disabled because of the pain. And that doesn't mean that we are more weak, or that is actually we feel it. And pain is very subjective, but the scales that it's been used throughout research to measure, they actually make that subjective experience objective, because then we can compare it with other people. And it is true that women are more sensitive to experience pain, and it usually has to do as well with those hormonal things. There is other things apart from being female, to, for example, your socioeconomic background. So the lower socioeconomic level that you have, the more you perceive the pain as well as a big threat. It can be because obviously you depend on your job, and you have a very manual job that you depend on your body, and therefore a pain is suddenly taking over your life. So the catastrophizing as well is higher. So apart from the socioeconomical and the sex, we also have things that we can modify. So obviously we know, for example, sleep. If you don't have your good sleep, or if your sleep is very disrupted, your pain also has lower threshold, so it means that you're more sensitive to pain. And I don't know if you ever obviously worked night shifts as well and all that, and after 2-3 night shifts you have a headache and it's like the whole world is collapsing. And I remember just crying out of pain, and it was nothing, but it was like anything just becomes too much when you don't sleep. New moms as well can perceive pain much more because of obviously this lack of sleep and all that. And menopause is a big one as well. You don't sleep as well, so therefore you can experience pain a lot more. So looking after your sleep patterns and sleep hygiene is basic, not to feel more pain. So it's another of those modifiable lifestyle changes that definitely affect on the quality of the pain and improving your pain threshold. Then obviously it's the general inflammation as well. So people that have bad diet, are obese and have high levels of inflammation within the body, perceive pain as well a bit higher. So good diet helps to feel pain, give you better tools to fight pain as well. And I think overall the mood as well. So if you are not feeling great, if you're feeling quite sad, if you're actually depressed, if you're not feeling amazing, it's like anything becomes too much, and pain actually becomes also less manageable and becomes bigger. whether it's because depression or it's just because you're not having a great day. Things that you can do about it obviously is looking after your mental health. And for example, exercise helps with all those endorphins to increase the mood, and when your mood is better you feel less pain. So exercise can actually help as well to perceive the pain a bit in a more manageable way as well. I think it's important to say, as you see in the photo, there's different levels of the generation of the cartilage. So you would think that the more deterioration, the more bone on bone, as people call it, the more raw everything is, the more pain. That's not always the case because of all these factors that we just discussed. But obviously the more raw the cartilage is and the more severe the arthritis is, the more muscle stiffness and lack of range of motion and the more debilitating factors. So obviously that also affects the way you feel, and the more you feel more debilitated and more disabled, the more that you're going to feel the pain being too big for you. So I think keeping things or managing things on time, so you actually maintain your independence and you have all those tools to maintain your body as healthy as you can and create a relationship with it. I think when you have a chronic illness, you need to create a relationship with the illness and learn how to look after your body and listen to it. If you catch that on time, you won't get to the point that the illness will make you depressed. The depression will give you more pain. The more pain makes you more ill. The more illness gives you more, and you're in that cycle that you cannot break unless someone comes and snaps it off. So manage it on time.
Not the leg.
Yes, not the leg, but the other cycle.
No, that's amazing. And in terms of the managing pain, you've talked about sleep, diet, managing depression. Are there any, I think it's important also to think that those will be limited to certain points. So, I think it's important to say that it's actually okay to take pain relief. I think, a lot of people think they have to kind of soldier on and, do it without. So, kind of what sort of pharmacological therapies are there available to people to help them manage their pain?
So obviously you always go with what your GP prescribes you or what you usually take for a headache or your own pain management. I'm not prescribing anything here, so you know what you have in your house or what you have prescribed. But there is different resources, usually for arthritis, which people get prescribed as anti-inflammatories to fight the inflammation as well, because that joint can get suddenly flared up and all the swelling, inflammation. Things like paracetamol is not enough, so you really need to get that anti-inflammatory effect of the medication. I would say, and it's something that I really tell my patients, I am a nurse as well, so I know where I come from. It's not like medication is not worth it. No, of course, it would be ideal that at some point you wean yourself off it. That would be ideal for everyone and saves lots of money to the NHS, to be fair. But it's very important that you don't chronify your pain. If you feel pain at a severe level and you keep living with the pain, you sensitize your tissues, which means that even if we do a lot about it, even if you do exercise, manual therapy, physical therapy, TENS, and loads of things, your brain will still perceive the threat because it's been in such a high level of pain for so long. It's sensitized to it. So it's very important to prevent your body to be in pain for no reason for a long period of time. You really don't want to affect your nervous system that much that then you live with that chronic pain, no matter what the state of the tissues really is. So it's very important to manage pain. I think pain management is key. And in the first stages, you will need medication when the pain is very bad, and it is fine. In some of the cases, heat or cold therapy might be enough, and you might not need to take a tablet. You might just want to put some cold tissues or maybe just some cold effect cream, or just put heat on it, depending what your body calls for it. And it might be enough. And sometimes massage, physical therapy, also once a month, to just go and kind of break all that stiffness around and bring everything kind of more neutral in place. It might be amazing. But you definitely need to do things on your own to manage your own illness. I think with osteoarthritis and chronic pain, we need to take ownership of it, and we need to do it ourselves. It's not just depending on the physical therapist or depending on the masseuse or depending on the medication only. So exercise is one of the main things, and it's proven by science that exercise reduces up to 50% the level of pain. It's not just going to the gym twice a week. what is proven is that people that do 2.5 hours of active, very active, high impact exercise, but then sit for 10 hours a day, still have high levels of pain. The way of decreasing the pain through exercise is having regular, constant activity. So walk in the house, go out, walk the dog a tiny bit, then do your gym, then half an hour here, half an hour there. Just keep moving during the day. Don't stay sitting for 10 hours in a row, because that doesn't help even if you don't go to the gym and kill yourself for 2 hours a week. You need to keep the activity going during the day. And that links to when we described that capsule with all the synovial fluid. What brings all the nutrients and all the nicest stuff into the cartilage is movement. Unless you move, that fluid won't really feed the cartilage. So the less you move, the more stiffness. The more stiffness, the more the muscles really contract and atrophy, and then feel pain and are more sensitive because the fascia is already getting tight. There is less sliding and gliding of all the tissues. And the more inactivity, the more stiffness, the more pain. The more pain, the more things get very stuck in the joints. So the more friction. And exercise, mobility, just moving around, just walking, it's enough to keep that improving. This screen now slide here, it's I don't know if it's very obvious, but on the right side we have a knee that has very thick and small muscles. So you can see the one on the left is nice and chunky, while like the one in the right is someone that doesn't walk, someone that is just kind of sedentary and having a very weak muscle mass. And in that case, the joint space is also thinner, because it's like everything is kind of falling on its own. It's not really held in place nicely and having a good kind of space and health in the joint. Going to the gym actually improves not just the mobility, the range of motion, the mood that is going to make you feel better. If you do a strengthening, those muscles are going to get thicker, bigger, stronger. And strong muscles are big support for the knees. So those bones are nice in place. So there is more space in the joint. There is more space for that. There's more mobility for the fluid to get where it should be. And things are more smooth and they move better, which means less pain, because those are bone to bone, those wasted surfaces are not really touching each other all the time. So that really helps with that osteoarthritis and all that joint pain, just exercising. It's not about high intensity or high impact exercise. So don't go now to do Zumba or to go running if you have pain. What is by research demonstrated that helps is a strength and endurance and balance. So going to things like what you do. So what you do is amazing, because you work with low impact, but you still keep people getting stronger and creating endurance through cardiovascular work that doesn't really put them at risk of having falls or at risk of having high impact going through the joints, and increase the balance as well. So those are the three things. And I would add then breathing work. So breathing work increases as well the thoracolumbar mechanism, which is also key in the posture, which is key in the health of the knees. So if you have a bad pelvic tilt or a bad hip mobility, the knee is always going to be a high risk as well, having just because of biomechanics. But those three things, balance, strength, and endurance, is demonstrated by research that actually helps the health of the knee. So the kind of thing you do, it can be even chair exercises when you are very poor with pain, or yes, you can really tolerate being standing because your pain is too bad on the knee. So,
and I think that's really reassuring, because I think, you know, a lot of people, when they have lower limb sort of injuries, is that they can't train at all. And actually, you know, being in the chair, you can potentially sort of, you know, take the impact out of that joint, but you can still work the other parts of your body. So, you know, I do a lot, even in my sort of chair strength and balance or chair cardio, we do a lot of upper body work, especially working the back muscles to create, you know, promote that better posture. You know, stretching our chest muscles quite a lot, because often we sit in that kind of contracted position a lot of the time, you know, sort of in younger age at the desk, even in older age as well. So again, stretching those muscles, strengthening those back muscles, and trying to get an overall good balance in terms of your upper body. And even in your lower body, you know, even if you have a painful knee, you know, hopefully it's just the one, but sometimes it can be both. You know, it's just working around it a little bit as well. So, you know, you might not be able to put as much impact into that side, but again, train the other limbs. That's really important as well. And that will certainly have an effect on the other limb as well, won't it? So, you know, it does have a bit of a crossover. So, So, brilliant. Yeah. And I was going to ask you something else actually. Sorry, I've interrupted you, haven't I?
I can't keep talking, but it comes back to you. So according to what you're saying, working the upper body, for example, when we have a bad posture, like a upper cross syndrome or round the shoulders, it is proven as well. It changes the way we feel. So when we stand very proud, we feel better. When we stand like that, our mood actually gets worse. And so you can see someone feels depressed and is depressed and works like that. Someone that is very happy opens up. So our posture changes the way we feel. The way we feel changes the way we feel pain. So it's key to actually work out the whole body to make the knee better. If we have very poor course on the spine, for example, if our breathing mechanics are not good enough, it's going to affect the way our pelvic floor, the hips and the pelvis sits. If our pelvis is not sitting level, but is actually having an anterior tilt, we're going to snap the knees back, which is most of the issues that cause that pain on the back chain, maybe the top of the calves, maybe the hamstring, that muscle pain at the end, and also a tiny bit of friction from the patella, because the knees all the time overstretched. We're not really standing with nice relaxed knees. We're all the time snapping them back. So we really need that pelvis tilt and upper back and all that posture to be worked out as well. So even if you have lots of pain, there's lots you can do even without moving the leg to improve the knee. And I think in my case, when I work with people that come with knee pain, obviously if it's an injury and it's the ligament, we go into that, but always there is that all body approach, like why this happens. So is your ankle mobility good? Because if you have poor ankle mobility or your feet are very bad, so pregnancy can also mess up with the arches, menopause can mess up with the arches, or depending the shoes you wear as well. If you wear loads of Wellington boots, for example, because you walk your dogs loads, it can mess up with the mobility of your feet as well, because you're all the time kind of losing that kind of nice walking, because the Welling boots can be a tiny bit funny. So if you lose that within the foot, it's going to affect the knee. If you also lose mobility at the hips because you're sitting all the time, as you were saying, that's going to affect the way your knee is. So we always need to assess the whole body. And doing a program like the ones you do, where you assess the whole body, it also has an effect on the leg. Even if you don't move the leg on that session, it's very important that you have some kind of, just own it and go and have something done for your whole health, even if it's just doing breathing exercises that are going to improve the way your overall feeling improves, and also posture improves, so you will feel more able to cope with a tiny bit of pain. At the same time, you will have better capacity to have better posture, which will impact the knee.
Yeah, no, that's amazing. So in terms of going back to like the kind of balance exercises, you know, that kind of like trying to stabilize the joint, is that you know, do we want to be doing that, you know, a couple of times a week? Do we need to do that daily? You know, what's your thoughts on that?
Well, I think it's very important to make sure that the leg muscles are balanced within the functionality of the muscles before we go into balancing exercises, because if we overusing or relying a lot on the front of the leg for balance, we may be overworking the quads and the hip flexors when we go into one leg stance, or we do some kind of balancing on one leg exercises. So I think exercises with balance should be just part of the functional program. Every single time you go training, you should do it at the same time as you train the whole body. So you can do a lunge, and as you come up, you bring the knee up, and you're already standing on the other leg, and you do lunge, and then the leg up, and you're already doing like a walking motion with exercises. That is balance. As soon as you come out in a transverse plane or frontal plane, and you move a tiny bit out of place with maybe a little ball in your hands or a little weight that is already challenging your base of support, that is balance. That doesn't mean that you need to stand on one leg for 2 minutes. I don't think that's really
sort of in that pose.
That's what, that's not balance exercise. Well, it is, but balance exercise is part of the functional training and should be done as part of every single session, part of the exercises, to make sure that everything is working balanced, that everything is being fired up, and you're working the glutes as much as the quads, as much as the hamstrings, as much as your upper body and abdominal muscles. So you're actually working with functionality, not just with balance as one, but it should be part of every single training session.
No, that's brilliant. I think we've covered everything that we wanted to cover.
Good.
And yeah, if anyone's got any questions, I'll just have a quick look, because
relationship with that pain, and do all you can do to manage it and know how to live with it in a healthy way. but you still don't have an assessment. You shouldn't be having pain, you should have it checked. So if it's something that you think is, usually when it's arthritis, it hurts in the morning, and it hurts for like 1-2 hours, and it's the worst part of arthritis is the mornings. It's not something that as soon as you do your steps eases off. It's something that stays there for quite a couple of hours. If it hurts after the activity or in the evening, usually it's related to what you've been doing during the day. So it's triggered by something that you've been doing and the way you use your body. So if it's by sitting, it might be just, and it's in the back, is that? Along my knees angles, they ache. So they ache. Obviously, you need to have an assessment. So do they ache like within the joint? Is it in the back? Is it in the front? Is it when walking? Does it get worse when with exercise, or is it after the exercise? Does it click? Does it lock? Does it give way, or is it just an ache? Is it what makes it better? If you put heat, does it go away? If you have a nice hot bath, does it go away? Or if you go out in the cold to walk your dog in the evening, does it actually get worse? Does it get worse because of the cold? So all those things you need to think about and take them to either your GP or a physical therapy, osteopath, or whoever you want to go, whoever you decide to go. But definitely have it assessed. They shouldn't ache. Chances are it might be postural because of the way you're sitting, or might be obviously some kind of muscle related imbalance as well. If it's both knees, I wouldn't think is arthritis as much, because usually it's one first and the other. It usually doesn't reach both at the same time. But I would have it assessed, just think about what things make it better, what things make it worse, and go and have it a check your posture, check your desk, make sure someone checks the ergonomic of your desk, that your desk is set for you, that you have the right height, so your knees shouldn't be higher than your hips to start with, because that also prevents the blood supply to go to the muscle, so your knee can complain because it doesn't receive the things it needs. So your knees have to be lower than your hips just a tiny bit. It helps your hip flexors, which is biomechanical as well, going to the knees. And so your feet should be on the floor. So if you all the time tiptoeing, that also puts pressure on the calves. So that also goes with kind of deep pain on the knee. So check the ergonomics of your desk and check about the characteristics of the pain and go have it assessed, because pain is more normal. Yeah. And blaming age is something that most of the population do and is not right. Age doesn't mean that you should have pain. Age is just a number to retire and go cruising around the world. It shouldn't really keep you from enjoying life. You should still be pain-free.
Yeah.
As much as possible, of course.
So she says, I will get to the GP. Thank you so much, Abi.
Oh, you're welcome. I seem so bossy. You have to go now, isn't it?
Martin asks, is a burning sensation a sign the knee is getting better, especially after walking?
So is it burning or is it stinging? Because I find people usually confuse that. So if it's like a stingy, usually it's fascia and it's hypoxia. So that means that the muscle is being overstretched or working in a stretched position, which usually means that you are actually snapping the knee back when you're walking. So you're depriving the tissues from getting all the oxygen because you're not really using the whole length of the muscle. So if it's like a stinginess, that means that is the muscle, there is the range of motion within the joint and the muscle is complaining. If it's burning, it's usually fascia creating, like there is adhesion, so the fascia cannot slide within the tissues. So that usually gets released with a tennis ball or with a bit of massage. If you rest and give it a nice shake and a nice warm up and you just mobilize and self-massage, usually that goes away. But a stinginess means there is lack of oxygen in the tissues, and burning is the fascia usually just complaining because it's just not sliding properly.
Okay. Lovely. And then Mo says she takes Letros. Oh, I'm not. Is that spelled right, Mo? I'm not sure.
Tablets.
Tablets. And my joints ache every morning. I get up, but now seems to go quicker now that I run regularly. Do you think I would feel better in the morning if I exercise later at night? Is this a side effect of the tablets? So
I think those are the cancer tablets. Yeah.
Yeah.
I think those treatments can be quite aggressive into joints as well. I wouldn't put my hand on the fire to say that I have something proper accurate to reply to these. I don't think doing exercise in the night will change anything if you're taking the tablets at the times you usually take them. Doing exercise at night has an impact in our hormones. So if you do a very high intensity training like running at night, it might actually change the quality of the sleep, so you might take longer to fall asleep, so it might not be ideal. While if you do gentle exercise towards the night time, you might actually feel better because you had a nice rest sleep. Also, if you do very intense exercise and you don't stretch properly, it might be that you actually feel a bit stiffer in the morning, so I would always add mobilizations, stretches, and kind of dynamic stretches after that active exercise before sleeping, if that's the case, if you want to change the time of the day. I don't think that would change. Obviously, if that's the side effect of the tablets, if that might be because you actually commenting it as they come together, so in your gut you think it comes linked to the tablet. The fact that you're running, as we said, brings mobility, brings a strength, so it just puts your knee in a more neutral and more ideal position to actually fight any aches and pains. So you're giving your knee all the tools for it to be happier. You're creating more space in the joint, you're giving more mobility, so nutrition to the cartilage, you're giving a strength on those muscles, so you're preventing injuries, you are keeping everything more congruent because you're keeping things strong and in place. So you're giving everything to your joints. Obviously, you're doing also strengthening with Emily, you're not doing just the running, so you're also doing all the exercise that is not high impact, but you're giving your knee what it needs to be happier. So keep doing that. I don't think changing the time of the day would have much of an effect. And you also have massage regularly as well. That definitely helps. And you have the best massage ever, don't you? Which is me. Sorry, she's like my mom. I'm just joking right now. She actually does everything. It's like by the book. She's so good. She's so good.
And yeah, definitely waving the flag for mature women. Yeah, definitely. I would say, Mo, is it just generally your joints, or could it just be generalized bone pain? Because a lot of anti-cancer therapies do cause sort of generalized bone pain just because of the mechanism of how they work. So a lot of the our immune system and our cells are produced in our bones, so that's how they work, and often they can cause a lot of bone pain. Again, it's just managing that achy feeling by what Abi's saying and reiterating that, you know, exercising and all of those endorphins, things like that, managing that. And if it is particularly painful, you know, if it's particularly achy in the morning, again, just mobilizing and getting that blood flowing in your body will just allow to, you know, in a way, just not even, you know, thinking about it as well. So right, next one is Sharon. I get pain underneath my kneecap on both knees when walking up and down the stairs. It's intermittent and sometimes means I cannot do squats or lunges.
Okay, so underneath the kneecap means between the kneecap and the other bones. So basically it's that kind of superficial, but it's not right within the joints. It's like just there that you cannot touch it, but it's a very annoying one. Does it feel like also crispy and sandy? Usually that means also there is some wastage of the surface of the patella because of friction that has been there for a long time. And if that's the case, or if there is some kind of tracking problem of the patella is outside of the place, usually there is still more wastage. So sometimes that stays there once it's been there for a long time and it hasn't been looked after. Going up or downstairs obviously means that the problem is worse when you have more range of motion and when you rely more on the quads. So when you flex your knee and then you rely on the strength to go up as well, that means that you are tracking even more from that patella. So I would say that comes from also glutes, weak glutes as well. You're relying too much in just one part of the knee. So you're relying too much on the front of the knee, which is putting pressure down the patella. I don't know if you can put maybe the photo of the first knee, Amy, so she can have an idea what I'm talking about.
Yeah, I'll just share the screen again.
Yeah. When you rely too much on the front of the knee, on the front muscles, like the quads, you usually get this issue with the knee because you're not relying on the whole leg to pull you or to track up. So that's it. So when that muscle that is crossing over the patella, it goes down, and that white tendon that crossed over, that muscle is working very hard, basically pulls the patella and really squeezes it against the muscle, against the other bones. So it's constantly being squeezed, which creates lots of friction behind it. I would say massage on the front of the quads can help. So if you self-massage the front of your quads, you can use a tennis ball or a foam roller. But overall, I would say go have it assessed, because there you can get exercises and physical therapy to balance a tiny bit the forces that go from the upper body to the lower body, from the mobility on how you go upstairs and stairs, where are the foot pressures, so if you go on the heel or you come on the forefoot, and depending how you step on the foot, the mobility of the ankle, the mobility of the hips, you can get more force coming through the back of the leg, and that way creating less tension on the front of the leg, mostly because obviously it's just associated with those two movements, which actually come with hip extension, flexion. So I would say definitely have it checked, so you can start massaging the front of the legs, see if that helps a tiny bit, from rolling it, tennis ball, and eventually then go for when we open after lockdown, go have it checked with a physio, and get strategies to strengthen the whole leg.
I think that's it now, Abi. Yeah, I think those questions actually kind of put a lot of what you said into practical application. So I think that definitely kind of summarised it a bit nicely actually with those questions. So thank you everyone for participating and coming. If you think I'll be rolling it an exercise and getting it checked out. Brilliant, well done, Sharon. So thank you, Abi, for coming, and I've learned loads from you, and you've been such a great mentor and friend, and someone I truly look up to. You're amazing. So thank you everyone for coming. Again, I'm terrible at selling myself, so the people, obviously my clients that are here, I offer sort of membership for £20 a month for some online strength and balance work. I do some boxing, so working that stability, our coordination. I've also got some sort of low impact HIIT, so if you still want that bit more of a higher intensity feeling, but don't want to be jumping around doing high level burpees, this is where you need to come. So I also do sort of chair cardio as well. And I actually on my strength and balance session earlier yesterday actually, I've got women that come to my higher impact stuff that come to that one as well. So even though it's sort of a shorter one, I've got people in their sort of late 40s, early 50s, ranging up until in their 70s. So it's really lovely to see different generations sort of working out together, and essentially for the same goal. So it's really nice to see. So if you want to learn a bit more, then by all means give me an email or message me, thank you, Abi, for coming.
And I can tell I do the boxing classes with her because I don't like the high intense. I'm more into strengthening and all that, and I can say the atmosphere she creates is amazing, and you just need to start preventing things before they happen. She can just do it online, so it's all in your house, and it's just amazing the way you can get stronger and fitter without really feeling so self-conscious in a gym. There is many things that you can do to actually look after your health without feeling out of place. And what you do is amazing. I think it's so welcoming and it's so worth trying.
And I think that's the important thing is, I will add, is, historically, I've done a lot of research around, kind of what's available to people. And I've spoken to a lot of sort of full specialists as well. And a lot of the programs that are put on for people in sort of group exercise, pre-COVID, when we could actually get out and exercise together, just wasn't challenging enough. And I think that's just down to, professionals just not thinking that they might harm someone, but actually they do need a bit of a challenge. And I know that people that are attending here, who have done my high intensity stuff, but then also come and done the sort of ones that are aimed at older people, or people with limited mobility, they're like, actually that was quite challenging. And so I do try and challenge people within their limit. So it's just teaching them what they can do, how they can limit it themselves, you know, with what they can do with their own range of motion, you know, and still getting, you know, a challenging workout that's actually going to be effective at building muscle. You
and
know,
it's not just the building muscle, because as obviously my field as well, it's all about challenging. It's not just challenging the strength or the endurance that you feel that you're gonna die. It's challenging the brain. So it's creating new neurological pattern of movements. It's making movements that you don't do in your daily life, or that you don't do right using the right techniques. And it's creating new pathways and pathways of movement that in the end are going to bring that balance between muscle groups that are going to protect your posture and your pain and your joints. So it's that you need that challenge to actually get fitter. If you just do what you do, so just actually keep doing what you're doing. Just don't pay for anything.
So I won't
you
keep,
need the challenge for the brain, the muscle, the range of motion, the balance, to change the nervous system and rebalance the muscle groups and create a strength and create balance and change. You need challenge to create change. But it's a good challenge that shouldn't be that you feel like you're going to die. So it's always within that attenuation scale where things are actually under control with a professional. So that's fine.
Definitely. Lovely. Well, thank you everyone for joining, and yeah, I'll quickly put the